much everyone for your patience listening. So, good evening and a warm welcome to all the dignitaries present here. I'm Srivshi from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Planet serves as the digital partner for this event hosted by the Indian College of Anesthesiologists, and the focus of today's session is journal scan. So let's begin today's session, for which I would like to invite Dr. Jayashree Shud ma'am to take over. Over to you, ma'am. Kindly proceed with the talk.
Thank you so much. Good evening, everybody. It's a proud moment for us today, the ICA, because we are going to now start the 201st session of our ICA webinars, which we are conducting consecutively since the last 4 years. So it's a very proud moment for us that we have done all these webinars uninterruptedly. And welcome you all. Today is a very, very interesting journal scan webinar, and we have elite neuroanesthesiologists, Dr. Sanjay Agrawal, Dr. Priyanka, and Dr. Ankur, and who are experts in their fields of neuroanesthesia, and we will be hearing from them about the journal scan today. Just to let you know, the ICA Con is going to be held. This is the national conference of the Indian College of Anesthesiologists, is going to be held in Lucknow this year, and you can get all the details over here. And please do register and make sure that you're there. You're going to have very nice orations, posters. You're going to have a session where the youngsters will have counseling sessions, what to do and how to pick up once they graduate after their MD anesthesia or DNB anesthesia. So please do that. We have another PG assembly. This is the first PG assembly under the aegis of the Indian College of Anesthesiologists. This is going to be held in New Delhi. So this is again in July this year. Please do register. You have everything on our website. So with a few of these introductions, now I would like to invite Dr. Sanjay Agrawal, who is the HOD at the AIIMS Rishikesh. And please, Sanjay, go ahead with the journal scan. Thank you so much.
Thank you, ma'am. Thank you. Thank you very much for the kind introduction. And for this, today's journal scan on neuroanesthesia, what we have planned is 2 lectures on very important topics which pertains to neuroanesthesia, which both a neuroanesthesiologist as well as a general anesthesiologist should know. So the first topic for this is the ICP monitoring, the modalities and the waveform analysis, which will be taken over by Dr. Priyanka Gupta. She is working as an additional professor at All India Institute of Medical Sciences, Rishikesh. She has a educational qualification of MD and DM in neuroanesthesia from AIIMS Delhi. And she's very active in academics in the department. And she will be talking about intracranial pressure monitoring, the devices, and how to interpret the different waveforms which are usually available. The second speaker with us will be Dr. Ankur Khandelwal, a well-known figure in neuroanesthesia circuit. He's an associate professor at AIIMS Gauwahati, and he'll be talking about the anesthetic perspective in dealing with a case of cerebral aneurysm, either clipping or coiling. And at the end, we will be having a few recent general scans which will be there, which will be taken up by me. So not taking much time, and now pass over the mic to Dr. Priyanka Gupta and request her to start her presentation. She'll be. Dr. Priyanka, please. Dr. Priyanka, you can start your presentation.
Yes, sir. I'm sharing my presentation. Good evening. My talk will be on different modalities of ICP monitoring, that is intracranial pressure, and how to analyze the ICP waveforms. So sir has already introduced me. So I'll directly go on the topic. So we should know a little bit about the history, how the ICP monitoring started. The first ever ICP monitor which has been documented is done by Henry Quincke. That Quincke is the same which who have devised Quincke's needles. Okay. So what he did lumbar puncture and connected to a manometer, and so he said that there is something is called intracranial pressure. It is some pressure is there which we can monitor. Later on, Mr. Dr. Jani, who is a French scientist, then neurosurgeon actually, he had his thesis, and that thesis was based on the intracranial pressure waveforms. And first ever that still we learn is Dr. Lernworks. He is a neurosurgeon. He he recorded at least 400 patients for roughly 1 week for each patient, and that he gave that famous Lernworks ICP waveforms A, B, and C. So we should know why we are concerned about the intracranial pressure. So as Monroe Kelly has said that intracranial pressure in cranium is a closed wall. It has three components: brain, CSF, and blood. So if one component has to increase, the either one or two component has to decrease. So if that change in the pressure with either increase of either of the component says that it says about the compliance of the brain. So that is the main logic behind the monitoring of the intracranial pressure. So what are the rationale? So why we should monitor intracranial pressure? To know the consequences of intracranial volume changes on the intracranial dynamics, to prevent consequences of brain herniation. So like we do promptly we treat it to prevent compromise severe, because once the ICP is above a threshold, cerebral perfusion will also be compromised. To know about the intracranial compliance, so how much we have time or how much we can wait. So normal intracranial pressure in a full-term infant is 1.5 to 6 mmHg. It varies depending upon the different body positions and straining, coughing, etc. Young children, it is 3 to 7 mm of Hg. Adults and older children, after roughly 10 years of age, it becomes 10 to 12 years of age, it becomes 10 to 15 mm of Hg. So what is pathological? Still, we cannot define exactly what is called pathological intracranial pressure. Some say that is between above 15, some BTF says it is above 22. So roughly between 50 to 20 intracranial pressure, it is a worrisome. And ICP of more than 40 mmHg may indicate impending brain herniation. So where we can monitor intracranial pressure? So we all know head injury. Head injury is the one of the most commonly used indication to monitor intracranial pressure. Nowadays, poor grade SAH are also commonly monitored for intracranial pressure. Intracranial hemorrhage, intracerebral hematoma, meningitis, encephalitis, patient with hepatic encephalopathy, benign intracranial hypertension, and sometimes intraoperatively or and postoperatively where the risk of high risk of perfusion breakthrough is there. So ICP monitoring is broadly divided into invasive techniques and non-invasive techniques. So I will be talking first about the invasive monitoring. So invasive monitoring is anything we put in the brain. So we can classify these techniques based upon their methods of pressure transduction. So either it may be principal, these all are the biophysics. Strain gauge pressure transduction, it is like same to as our arterial transducers. Okay, it may be intraventricular or it may be external or it may be internal also. Second commonly used technique is the fiber optic technology. Fiber optic is that light is transmitted, light is reflected back, and the change in the reflection amounts to is amplified and recorded as a pressure change. Other are fluid coupled devices. That is same as like we monitor as our arterial line pressure. And there is non-fluid coupled devices. They are also based on the fiber optic or catheter. That is another way of classifying. Means fluid coupled means they are hollow. Non-fluid coupled means they are not hollow. So no fluid is connected between brain and the outer system. So where we can monitor ICP? So ICP classically or gold standard technique is to monitor in the intraventricular site or intraventricular pressure. That is we do by connecting with the external ventricular drainage. Other common one used in the current scenario is the intraparenchymal. So we put in the non-dominant hemisphere or area of interest, and we put a small catheter in the parenchyma, brain parenchyma. Other techniques are there, that is subarachnoid bolt. However, they are not very accurate techniques. And older time epidural and subdural technique also has been devised, but it is no more used, and because they are not accurate, and we cannot validate their results. So intraventricular pressure monitoring is a gold standard technique. Gold standard means all the remaining technique has been validated as compared to this technique. So it is same as we through burr hole. EVD catheter is put in the one of the lateral ventricle, and that catheter is connected to by a fluid coupled device connected to external stain gauge. We as a jugaad, we can also connect it to our arterial transducer also, and it can give the arterial waveforms also. So, but it has its own inherent advantages and disadvantages. So, major the advantages are because they are the most accurate technique. Like as we do zeroing in arterial line, we can recalibrate. And recalibration here, the point of recalibration is the external auditory matters that correspond to the foramen of Monro. They are more accurate. They are diagnostic as well as therapeutic. We can inject drugs. We can do CSF drainage to reduce ICP also. We can inject antibiotics also. However, they are more prone for the kinking, blockade by debris, protein material, clot, airlock is possible. So these devices over the time may not function properly. And another the most grievous or grievous complication if possible in these patients is the infectious complication like ventriculitis, meningitis. Brain Trauma Foundation says that we can keep them and at least 7 days, and a prophylactic antibiotic to prevent infection is not required. But only thing which we can do to prevent infectious complication with this type of monitoring or this type of drainage is avoiding flushing. And routine ABD catheter change is not required. We can also to reduce infection, we can also tunnel in the subcutaneous plane also. And sometimes over drainage of the CSF can lead to reverse herniation. Sometimes imbalanced drainage can also lead to interhemispheric herniations. So this is one of the picture showing this is the ear, external auditory matters of the patient, and this is the transducer. And this we can zero here, like arterial transducer. It is connected to ultimately to the cable, and it is connected to the monitor. This is the EBD bag. And like arterial waveform, we can also see the ICP waveforms also. So we can analyze not only the single value, we can analyze the ICP waveforms also with this technique. So next we'll go to subarachnoid or ICP monitoring. This is done by either subarachnoid bolt or Richmond screw. That is a hollow screw, and a screw is like a burr hole. It is screwed in the skull, and then it about the dura, and dura is perforated to fill the bolt with the CSF. Then CSF is connected to fluid filled line, and connected like arterial line only. It is connected to the pressure transducer. It is quick, very easy, and because it does not evade much of the brain parenchyma, so risk of trauma, bleeding, infections are very less. However, it leads to most of the time ICP underestimation. This bolt also can be blocked by the clot. The screw can misplace. It may move subdurally or epidurally. So these techniques, though less invasive, but routinely they are not practiced nowadays. So this is a bolt which shows this is a scan, and this is dura, and then it is a subarachnoid space. Epidural and subdural, they are not, they are very less invasive and they are easy and quick to place, but their accuracy is questionable because epidural pressure is because of the brain structure. Epidural pressure is more than the intraventricular pressure. So they, most of the time, they overestimate the ICP. So they are not a reliable techniques. Then come one of the Spiegelberg pneumatic sensor. This type of sensor can be placed epidurally, subdurally, intraventricularly, and intraparenchymally. And one of the main advantage of this catheter is it can be zeroed in wipe. Other than this, no other currently available intraparenchymal monitor can be re-zeroed. Or once they are zeroed, their zero drift will be there. Here, there is no, we can every hour, it can automatically zero itself. So this is also a fluid-filled catheter transducer system. There, in this, rather than the external strain gauge, which we have seen in the intraventricular and subarachnoid, all those techniques, we have seen the external strain gauge principle. Here, that strain gauge, that Wheatstone bridge is itself is placed inside the catheter. And catheter, the tip of the catheter is an air-filled balloon. And it is placed either in to prevent a risk of infection. It is placed commonly in the brain parenchyma using by same that bolting Kocher's point and burr hole and insert it. And every hour, the zeroing, the pressure transducer is at the level of near the monitor. Every hour there is a automatic zeroing possible. It opens to the atmosphere. So zero drift is minimizing this. But because of the limited bandwidth, ICP waveform analysis is not possible. These monitors also provide data about the ICP compliance that are similar to the other standard methods and other intraparenchymal monitors. And these monitors are also compatible with the 3T MRI. So here, this Spiegelberg is placed intraventricularly. Here, that it can be drained like a EVD, and this is connected to the monitor. So other intraparenchymal we can divide as the strain gauge devices and fiber optic devices. Among the strain gauge devices, we commonly use is the Codman microsensor. And newer one has come the Ronadic Neuroband P ICP sensors. And among fiber optic, we commonly use the Camino ICP monitor. So we'll talk about the Camino ICP monitor. It is based on the fiber optic principle. Like fiber optic principle, same we had in the fiber optic bronchoscope. It transmits light by a fiber optic cable. Fiber optic cable are very thin, fragile cables in the nylon sheet. And that light is transmitted, and it displaces. It falls on the displaceable diaphragm or mirror. Then the light, and there is some intracranial pressure. Then the diaphragm is displaced with the pressure also. So light is reflected off the diaphragm, and the light intensity changes. And that change in the light intensity is interpreted in terms of the pressure. So that is amounted to the more the change in the light intensity, it is higher the intracranial pressure. And all these, because these are small values, they need the amplifier also. So like it is also very advantage of this type of monitoring is that they are good. Sensitivity is there, accuracy is there as compared to intraventricular. They have good estimation near the intraventricular pressure only. But disadvantage is there because they are fiber optic cables. They are expensive. There is daily drift, roughly of 0.3 mm of Hg, if it is used more than 5 days. And once it is inserted, it cannot be recalibrated or re-zeroed again. And because they are fiber optic cables, they are fragile catheter. They are likely to have fracture of the cables. Then the common we use is the Codman ICP monitor. So I will be talking a little bit about its how to recalibrate zero, this type of monitor. So because this is the most of the institute, we commonly see this Codman intraparenchymal catheter sensors. So this is like a miniature solid state pressure transducer. They are mounted on a titanium case, roughly of 100 centimeter in length. The transducer tip contains a microchip, and there is a piezoelectric strain gauge principle is applied here. The advantages are that it is very accurate, stable. As compared to Camino, it is less expensive, flexible, and can also be tunneled subcutaneously. Disadvantage again, we cannot be re-zero them. It is daily drift of 0.13 to 0.1 mm per Hg and cannot be recalibrated. So how to do a insert? I will talk about the how to zero and recalibrate this sensor. So sorry, this is the monitor, ICP monitor attached with the cable. Okay, first we obviously will do on. Okay, we connect this cable to the ICP sensor here. Then we press the zeroing. So it will say that transducer is detected. Here the tip of the transducer is submerged in the saline horizontally. Now we press the zeroing. Once it is zeroed, then the like neurosurgeon and whoever is performing, they do burr hole and then insert. So this is the only time it can be zeroed. After that, it cannot be zeroed. So now because we all are technology is moving very fast, so everything is becoming wireless, charger is wireless, mobile is more, our earphones are wireless. So here our ICP monitoring also becoming wireless. We call now wireless and telemetric devices. So one of the device, they are still in the some of them are marketed, some of them are still in the animal studies and everywhere, but they are the future now. So one of the sensor I will talk about, the Neuroband TEL means telemetry sensor. It is a passive implant, which we can see. The implant is inside the brain. That blue tip is a sensor. Then there is a antenna, active antenna. Okay. Then this is the display or storage unit. So they are not connected. Once it is inserted, this remains inside the brain and they are connected. The signal are captured by the radio frequency signal. So ICP is monitored and transmitted by the radio frequency. And newer, even the advanced version is a telemetric, which like you put the sensor in the patient and forget. And in the mobile, you can see the ICP of the patient. So these devices are in the process of development. Similar principle is one of the another person who devises airbag wireless ICP monitor. Similar principle here is the ultra thin airbag for pressure sensing. This is the airbag, and this is the low power dedicated system on a chip. This is the chip, okay, and then wireless transmission by radio frequency signals, and data will be shown on the monitor, so that these things have been devised to minimize the risk of infections. Now, even one more step ahead is the bioabsorbable ICP sensor. They are in the process of development. Means once even they are wireless or telemetric, the patient has to come again in the OT to remove it back, or OT or whatever, patient has to undergo removal of these sensors. So to prevent even the removal of these sensors can lead to second brain injury. To prevent that, now comes the newer advances are that they are wireless, they are telemetric also, but they are also bioabsorbable. So they are making a material like polylactide and caprolactone, so that these ultimately they get absorbed in the brain itself and need not to remove it. They are need not to remove it back. So one of the paper was published in the Nature is about the bioabsorbable silicon electronic sensor, ICP sensor. They are still in the developing phase only. So now, as we want everything to be less invasive, minimally invasive, non-invasive, so here we are also, advancing in the ICP monitoring by the non-invasive methods also. So ear and our ear and our eyes ultimately connected to the brain directly, very close by. So these are the areas of interest where we can predict or monitor intracranial pressure. So first we'll go to the ophthalmic modes of non-invasive monitoring. So as we see that our optic nerves are directly connected to the brain, and CSF is also circulating. That subarachnoid space is continuing from the brain to the up to the retina. So increase in the CSF pressure in the subarachnoid space around the also increases the pressure around the optic sheet, and it ultimately can lead to obstruction in the circulation. If the pressure is too high, it can lead to the obstruction in the circulation in the central retinal vein. It can lead to papilledema. It can increase the diameter of optic nerve sheet. It can also lead to field effect and increase in the intraocular pressure. So these are the basis of devising ophthalmic way of monitoring invasive, non-invasive ICP. So because they are non-invasive, they are less reliable as compared to the, or less accurate as compared to the invasive ICP monitoring. So what are the, or how we can monitor? One of we all know that optic nerve sheet diameter. There are other ways also. The newer, I will talk about a little bit about the TDTD, that is two depth transorbital Doppler, because that has been marketed. Then visual evoke potential, like flash visual evoke potential, central retinal venous pressure. And I will talk little about the pupillometry also. So ONSD. ONSD has been come as a most among all non-invasive method, most reliable and accurate measurement of ICP. So this is the this is the optic nerve. This part is intraorbital, and here is the intracranial part. So this is optic nerve sheet. Then it is white color is the subarachnoid space, and that normal size of optic nerve is around 3 to 5 mm. Here, so what happens when the ICP is increased? CSF passes through the extra CSF, and extra CSF pressure passes through the optic canal to the optic nerve sheet, and it increases the optic nerve sheet diameter. It is a safe, rapidly detect elevated ICP, and it is very easy to teach also. The learning curve is not very prolonged, and individual variations are also very less. So in most of the studies have said that ONSD value of more than 5 mm is the threshold of the determining high ICP. And in some study, even like patients with the normal pressure, benign intracranial hypertension, they have seen that once they do lumbar puncture and they measure ONSD again, the ONSD becomes within few minutes, ONSD becomes less than the decreases, and it becomes less than the 5 mm. So in certain study they have not seen, but in certain patient it has been seen that ONSD comes back to the normal once the ICP is reduced. However, lesions of optic nerve, orbit, like in head injury, Graves' disease, sarcoidosis, eyelid tumors, optic nerve sheet cyst, orbital tumors, in those patients we cannot perform ONSD. So here just I want to show, sorry, this is the blue one is the optic, this is optic nerve, and this is the optic nerve, that CSF, subarachnoid space, and the optic nerve sheet. Here just see the nerve, the diameter of that blue space, that is subarachnoid space, has increased. So that is the what we measure in the ONSD. ONSD can be done by ultrasound, it can be done by MRI, it can be done by CT, but because it is non-invasive and bedside, as a bedside method, it is very routinely and commonly done by the ultrasound method. Here we put a 7.5 megahertz transducer probe here in both in longitudinal and sagittal plane. This is the globe, and 3 mm behind the globe we measure optic nerve sheet, that is inner line of hypoechoic here and hypoechoic line here. If that distance we measure, and if it is more than 5 mm, that is here it is just 5.5 centimeter. So it may indicate raised ICP. This is by MRI. Same 3 mm behind the globe, and it is 0.55 centimeter here. This is by ultrasound. This is same ONST. MRI and CT are much more specific and more accurate. So in many of the study, the accuracy sensitivity of ONSD has come to nearly 90%, and specificity to detect ICP is around 85%. Then comes which has been commercially available also, that is two-depth transorbital Doppler TTGD. It is also a mode of ultrasound only. Doppler. Ophthalmic artery. So we know that in this picture, this picture, this is ophthalmic artery. Okay, this is the intraorbital part, and then either the intracranial part, and this is the origin, internal carotid artery. So it is a unique vessel because it has a both intracranial as well as extracranial component, and it is a, so these are the two, it is made as a pair, and these their response, their waveforms in the Doppler, they are considered to measure absolute ICP. So what happens? The blood flow in the, as the ICP increases, the blood flow in the intracranial segment is affected because it will ultimately compress on the blood vessels also. So blood flow in the what we do to monitor ICP, if we similar to intracranial part, if we can reduce the blood flow in the extracranial part or interorbital part of ophthalmic artery, that can, if at one point the waveforms of both sides will become equal, and that pressure when we apply from the externally, and that pressure becomes ICP. So in this matter, it is little lengthy because gradual pressure is applied on the orbit, and roughly it takes by 16 minutes to complete one measurement. It is marketed by Vitamed Corporation, and so that it cannot be used as a continuous monitor. So this is the device. This is the eyes. Here the pressure is applied, and this pressure is measured. And when this is a Doppler probe, and pressure is applied, and once the waveform of the intracranial and extracranial ophthalmic artery becomes equal, at that is the amount of pressure is measured, and that pressure is equal to the ICP. Similar principle is also applied for central retinal venous pressure measurement. That is also same thing. We externally that venous pulsations are present in the, if IOP if intraocular pressure increases, central retinal vein pulsate, because veins don't pulsate, but once pressure is high, at that time veins can pulsate. So same thing is done to measure ICP. The pressure is applied, and once the vein started pulsating, that pressure is considered to be equal to the ICP. And then comes our new technique is pupillometry. So we all know that ICP changes our pupil. Pupil change. Automated pupillometry has been used to measure, to roughly measure ICP, because it not only measures the size, it measures the its reactivity, its speed to speed of reactivity also. So NPI is used to quantify pupillary reactivity. So in this picture, we can see here, this is one patient where we measure ICP. Okay, this is invasive ICP. So ICP is more than 25, nearly 30 only. And at that time, mannitol was given. And NPI was low, between 3 to 2. Anything less than 3 is abnormal NPI. So after osmotherapy, ICP start reducing. Here becomes 20, and then it's less than 20. And NPI increases and roughly becomes more than 3, and roughly 3, 4. So it may not be accurately measured the amount of ICP, but it may indicate that is that if we serially monitor NPI for these patients, we can see, okay, some time back it was 5. So after 5 hours, it becomes 2. So something have changed in the patient, and we have to correlate with the clinical years. Then comes ear, because we know that ear is also communicated with the CSF in the posterior fossa. Perilymph of the cochlea has communication with the posterior cranial fossa. So this is the basis of the non-invasive monitoring via ear. So one of the some of the devices are TMD, tympanic membrane displacement, and analyzing the autoacoustic emissions. So TMD, there are certain movement of tympanic, subtle movement of tympanic membrane when the ICP changes. Some says it goes outward, some says it goes, some says it when with the increase in ICP, tympanic membrane moves inward. So this is the technique where the this technique requires a patent cochlear aqueduct, because then only the CSF pressure will be transmitted to the ear. Then it also needs normal middle ear pressure. There will be no perforation of tympanic membrane, etc. And there should be a intact stapedial reflex, because that is the main, that is because of that reflex only the tympanic membrane will move. So an air displacement sensor probe seal the external auditory metal. It detects fluctuation in the volume, that is in nanoliters, of the external auditory metals. So stimulation of the stapedial reflex causes a movement of tympanic membrane, which is correlated to the ICP. But they will only say the ICP is normal or high. They will not give the exact value. Then come method of autoacoustic emission. Autoacoustic emission is because when the auditory stimulus are given, cochlea itself produces some sound. That is, they are called autoacoustic emissions. And these sounds are very sensitive to change in the intracranial pressure. And these emissions changes with the change in the intracranial pressure. But because they are inter-individual variability and we don't know the baseline of that particular individual, so they cannot be very these type of monitoring are not very validated, and these cannot be done in the patient with who are having sensory neural or conductive hearing loss. Then come because of the fluid dynamic or elasticity of the brain, there are other methods to measure intracranial pressure. So one of them is the MRI. We can do MRI can predict. There are formulas also, elastin index. However, if practically speaking, to monitor ICP, MRI is not feasible. Then one of the bedside method is TCD. So we all know pulsatility index, but TCD will be only be useful when ICP is that high that it is affecting the cerebral blood flow. So up to that, before that, they may not indicate anything. So PI, that is pulsatility index. However, it is affected by numerous factors, but increase in PI indicates increase in ICP. And there is the non-invasive ICP formula also has been devised to monitor, to calculate their mathematical algorithm. Then comes the cerebral blood flow velocity. It is also same principle that ICP increases the cerebral vascular resistance and cerebral blood flow velocity changes with that. Then come NIRS, because NIRS also reflect the cerebral blood flow. So ICP also affect the cerebral blood flow. It decreases the cerebral blood flow and cerebral perfusion pressure. So NIRS may decrease with the rise in ICP. They are just suggestive of, they are not absolute marker of raised ICP. Then another method by ultrasound is transcranial time of flight. That is like acoustic. If we put ultrasound in the brain, so whatever comes back, it changes with the intracranial pressure. But these things are also affected by many things on the way. So they are also not very validated methods. Then comes some electrophysiological. One of them I will talk is the visual evoked potential. Visual evoked potential, because all these pathway of vision goes in the inferior side of the brain, and these fibers are vulnerable when the ICP increases. So if there is change in the decrease in the amplitude of flash visual evoked potential and increased latency, they may suggestive of rise in the ICP. EEG is too cumbersome to monitor the ICP, so it is not routinely done for measurement of the ICP. Then comes so we have now, so all these methods, some of them have their own merits, some of them have demerit. Nothing is ideal. We are still searching. Then no, ICP is not a just okay 20 RI, 25 RI. No, ICP is not just a simple value. ICP is a continuum. It is it's a continuum. It is a, it is more than a number. So Pulse waveform of ICP combines both cerebral vascular hemodynamic as well as systemic hemodynamics also. And it also involves the cerebrospinal pressure volume compensation. So how these ICP waveforms arises? So there are many theories, nothing is still, things are still not, confirmed that ICP waveforms occur because of this. But they are, mainly it is the P1, P2, P3 waveforms have been devised, and they say that passive extension of walls of cerebral arteries due to systolic upstroke that causes P1. Then there is, after with each systole, there is increase in cerebral arterial blood volume, and then there is also fluctuation in the condition of for the venous blood outflow. So these three things causes ICP waveforms. It exhibits cyclic variations also are there that are superimposed on the cardiac contraction, respiration, and intracranial compliance. So we all know that P1, P2, P3. P1 is called percussion wave, that is equals a systolic upstroke. Here, see, this is a systolic upstroke. Just after that, the P1 value comes. Then tidal wave that says intracranial compliance, that is the blood volume of the brain increases. It comes later on. Then dichrotic wave or the P3 is like closure of the aortic valves. In the expiration, there is increase overall wave, and in inspiration, there is a decrease. Because we can say inspiration negative inspiration, so the value decreases, but expiration is passive, relatively positive is there, so it is higher. So, sorry. So here, if we say continuum of this arterial waveform, this change and this change. So W1, this is changes because of the arterial pulsation, each that happens with each within the cardiac cycle, and these changes in the respiratory cycle. So in this waveform, when the P1 is very prominent, it may suggest either CSF is too much or CSF is too less. If large volume of CSF is drained off, it may show peaking of the P1. And sometimes patient does not have a bone flap. Okay, ICP we are monitoring. So that time also the P1 can be high. P1 can also be high when the too much high BP. Too much systolic high BP also can lead to high peaking of the P1 wave. Then diminishing of the P1. Diminishing of P1 can happen because BP, when the BP is systolic BP is too low. P1 will only change with this. The P2 and P3 will not change because of the low BP. Then there is the diminished P2 wave. And that can happen because of the hyperventilation if patient is hyperventilating. And this pyramidal or trigonal wave, because where the P1, P2 are fused, or they are, it means that ICP is critically high and impending brain herniation is there. And flat ICP waveform, either the blockade is there, clot or air, or patient has expired. There is no cardiac activity. Then these waves are called time domain waves. Then there are controversial other waves also, which we say the Nils Lundberg and his waves. So Nils Lundberg, that is his own paper's language. What he says, among these, he monitor, I told that 400 patients, he monitor for a week. Every patient continuous monitoring interventricularly, he monitor for 1 week for each patient, and he has a huge data of 400 patients. So he says, among these, one type of is of particular because it is closely related to acute cerebral symptoms in patients with intracranial hypertension. This type of pressure variation is characterized by a sudden rapid rise continuation on a high level for some time, and finally there is a rapid fall. And I call them as a plateau wave. That is, we know as the Lundberg A wave. So ICP is increased and compliance is decreased. They are called pathological wave. They are of amplitude of 50 to 100 mmHg. Nils Lundberg say they come at least for 5 minutes. The duration is at least 5 minutes and indicate low CPP and ischemia and ominous sign for the herniation. Then also the Lundberg wave, V waves also we know as the pathological wave. They are rhythmic oscillation, sharply occurring every 1 to 2 minutes. The crescendo and decrescendo manner, 20-30 mmHg ICP, and there is a variable baseline. There is no not sustained. They reflect vasomotor changes associated with the unstable ICP. They may ultimately progress to the Lundberg A waves. Then C wave, their origin is not sure, but they are generally not considered to be pathological waves. So some trials has been done to monitor or not monitor. So one of the trial was Synapse ICU, and they monitor in the patient ICP in the acute brain injury due to either SAH, ICH, and also head injury. And they concluded that 6-month mortality was lower in patients who had ICP monitoring than who were not monitored. But later on, one more trial was is the best trip trial, and it was done in the patient with the head injury only. And they say that it was published in NEJM. There was no change. There was no difference between the patients who were monitored ICP and not. And there is a latest article, Crescendo Consortium. It says it was done in the patient with the traumatic brain injury only, and they said that ICP monitoring had a worse Glasgow outcome, extended outcome scale. Those who were monitored with ICP and as versus those were monitored with the CT and clinical. So the question of whether to monitor is inextricably linked with the method of monitoring. What we do with that information, when and how do we treat? That is more important. The true power to improve outcome in patient with intracranial hypertension after TBI or ICH requires knowledge far beyond this ICP numbers. Monitoring ICP may be important and sometimes very necessary also, but this is not only sufficient. So our clinical practice and clinical assessment and clinical science of raised ICP will never go out of practice. Thank you. Thank you very much.
Thank you, Dr. Priyanka, for extensively taking up the topic of ICP monitoring and telling us about a number of devices which are now available to us to monitor the ICP. Though there is a controversy whether should it be monitored or should it not be monitored. But this is a one armamentarium which is there in the field of neuroanesthesia, which we can use. And questionings we will be taking in the end. So I'll now invite Dr. Ankur Khandelwal for his presentation. Dr. Ankur is an associate professor at AIIMS Gauwahati, and his area of interest is perioperative neurosciences, trauma and pain medicine. He has a number of publications with 10 book chapters, and he is the editor of the book Futuristic Trends in Medical Sciences, an associate editor of MJAFI, an Asian Spine Journal, and JNAC, and has been awarded as KPR Young Anesthesiologist Award in 2022, Professor P.K. Singh Youth Award in 2022, ISNAC Presidential Award 2022, and ISA Young Talent Award in 2023. He is a ACA certified ATLS instructor, and Dr. Ankur will be talking about the anesthetic perspective of clipping versus coiling in a cerebral aneurysm case. So Dr. Ankur, I invite you to present.
Thank you so much, sir, for the kind introduction. At the outset, I would like to thank ICA for giving me the opportunity to be a part of this webinar. This is the fourth webinar for ICA in which whom I am speaking for. So today's topic will be clipping versus coiling of cerebral aneurysms based on the perspective of an anesthesiologist. I have nothing to declare. All the information furnished in the webinar are from standard books and high impact journals. So let us dwell back into the basics. What is cerebral aneurysm? Any bulge or ballooning in a cerebral artery due to weakened area in the wall of an artery. That is how we defined aneurysm. So based on shape, there may be saccular aneurysm, there may be fusiform aneurysm or mycotic aneurysm. We are all aware of this. Based on size, there may be small size when the diameter is less than 10 mm. They may be large aneurysm when the diameter is 10 to 25 mm, or they may be giant aneurysm when it is more than 25 mm or 2.5 centimeter. Based on location, they can be anterior circulation aneurysm, they can be posterior circulation aneurysm. Usually they are ACOM aneurysm, MC aneurysm or IC aneurysm. In the posterior circulation, it's more commonly the basilar top aneurysm or aneurysms in the basilar artery circulation. The pathogenesis involves a multitude of congenital and systemic factors. Most commonly due to vascular wall defects, we know there is vascular wall defect in the layer of external elastic lamina, or there may be discontinuity of tunica media, particularly at the origin of the small vessels from large parent vessels. Most commonly, this occurs due to the hemodynamic stress in the area of the branching of the vessels, and other contributors may be degenerative changes, hypertension, atherosclerosis, and connective tissue diseases. So risk factors for formation of cerebral aneurysms are usually divided into inherited and acquired. Inherited, it is more commonly seen in females. Patients with family history of aneurysms, polycystic kidney disease, AV malformations, and a bundle of congenital connective tissue disorders like Klinefelter syndromes, Ehlers-Danlos syndromes. Acquired, higher the age, higher are the chances of formation of cerebral aneurysms due to atherosclerosis, particularly more than 40 years of age. Hypertension, diabetes, atherosclerosis, alcohol, cigarette, head injury, or use of illicit drugs like cocaine or amphetamines, and at times due to infection as well. These are the risk factors for formation of cerebral aneurysms. What are the risk factors for rupture of cerebral aneurysms? These are most commonly smoking, hypertension, larger aneurysms more than 7 mm, location if they are commonly located in the pica, PCOM and ACOM. These have higher chances of rupture as compared to other located aneurysms. Aneurysms that grow over time are also at increased rupture. Family history of aneurysmal rupture, and as I mentioned earlier, female gender. Women have a higher tendency of aneurysmal rupture than men. So risk stratification for rupture of cerebral aneurysms, there are certain morphological index. What we commonly refer to in the clinical practice is the aspect ratio, which is the length, the fundus length, if you can see in the figure, the fundus length divided by the neck of the diameter. And if it is more than 1.6, then the chances of aneurysmal rupture are very high. So aspect ratio is very commonly used in the clinical practice. Otherwise, there are other indices as well: undulation, ellipticity, non-sphericity, bottleneck, and conicity. So more the lobulations in the aneurysms, more are the chances of rupture, and also the bottleneck factor, which is the maximum diameter by the neck diameter, right? So let us come to the clinical presentation. So aneurysm may be a ruptured or may be an unruptured. Unruptured aneurysm may come with incidental findings or may come with subtle symptoms. Usually they are asymptomatic until they become very large or rupture, but they may come with certain symptoms like pain above and behind the eye, that is retroorbital pain. They may have areas of numbness, weakness, paralysis on one side of the face, a dilated pupil in the eye, or certain sort of vision changes or diplopia. And how would a ruptured aneurysm present? Classically with a thunderclap headache, that is a sudden and extremely severe headache, and peaks usually within 1 hour of its headache, the maximum intensity is there. Associatedly, there may be nausea, vomiting, neck stiffness, seizures, diplopia, photophobia, or transient or brief period of loss of consciousness. So what is sentinel aneurysm or a leaking aneurysm? In few cases, there may be leak from the aneurysm prior to the actual rupture of the aneurysm. This occurs in usually 10 to 43% of the cases, and this is a warning sign. So also known as warning aneurysms at times. So why are we talking of aneurysmal subarachnoid hemorrhage? Why is it so important, or why is it so alarming? It's alarming because the worldwide incidence of aneurysmal subarachnoid hemorrhage is 6.1 per 1 lakh person years, with a global prevalence of almost 8 million cases. Very high. Pre-hospital mortality is as high as 22 to 26%. In-hospital mortality is as high as 20%. On top of that, there is additional burden of loss of productivity and long-term morbidity among the survivors. Treatment and rehabilitation incurs significant financial burden. That is a big problem if the patient develops complications, and delay in treatment worsens outcomes. That is why it is so alarming. So let us come to the latest evidence 2023 guidelines published by the American Stroke Association and the American Heart Association in the management of aneurysmal subarachnoid hemorrhage. So in the next coming slides, I will be sharing those recommendations in bits and pieces throughout my presentation. You can just keep noting these recommendations. So any patients who come with aneurysmal subarachnoid hemorrhage within 6 hours has to be done a non-contrast CT scan with or without a neurological deficit. That is where we find most of the diagnosis. You find hyperdense collections in the fissures or in the ventricles, or at times it may be large enough to cause an intraparenchymal hemorrhage. But what happens if a patient comes after 6 hours and without any neurological deficit? So you get a CT scan done. If the CT scan shows bleed, good enough. If the CT scan is not showing bleed, then the second modality of investigation is you have to go for a lumbar puncture. That is class 1 evidence. If the lumbar puncture also doesn't suggest anything, then you will have to go for a digital subtraction angiography or a CT angiography to get a final diagnosis done. Right? So in less than 6 hours, it is CT scan. It will give you the diagnosis, but in more than after 6 hours, CT scan may not be always positive. It may be negative. Then you have to go for lumbar puncture. If the lumbar puncture is negative for xanthochromia, you have to go for angiography either by a CT scan, CT angiography, or a digital subtraction angiography. Right? So what are the recommendations? How do you evaluate a patient with aneurysmal subarachnoid hemorrhage? The guideline says that prompt diagnostic workup and evaluation are recommended. This is a class 1 recommendation with the level of evidence B. So throughout the guidelines, we will be more focusing more on the class 1 and the class 2 recommendations, right? Because class 1 recommendation means strong evidence. Class 2 recommendation means moderate evidence. Beyond class 2, we are not that much interested because those are low level evidences. So what class 1 recommendation is? Prompt diagnostic workup and evaluation. This is a class 1 recommendation. Any patient who has come to you with acute onset severe headache, classically a thunderclap headache. Number 2, any patients who presents after more than 6 hours without a neurological deficit, lumbar puncture should be done to assess for xanthogramia. Again, a class 1 recommendation, right? If the lumbar puncture is not giving you details, you have to go for CT scan, CT angiography, or a DSA, right? Again, there is one class 2 recommendation. In less than 6 hours, most of the time CT will pick up the diagnosis. But if CT is, if the patient doesn't have neurological deficit, better get the CT scan evaluated by a very trained radiologist. That is one class 2 recommendation. So come to the evaluation of cause of aneurysmal subarachnoid hemorrhage. So in patients with spontaneous subarachnoid hemorrhage, with high level of concern for aneurysmal source and a negative or inconclusive CT, DSA is indicated to diagnose exclude cerebral aneurysm. That is again class 1. That is what I mentioned. CT, LP, DSA. Right? And DSA can also be useful to determine the optimal strategy for aneurysm intervention. So class 2 recommendation. So when we have come to know that yes, it's a case of aneurysmal subarachnoid hemorrhage, we need to grade them. Grade them either clinically and grade them by radiology features. Why we need to grade them? To know the severity of the subarachnoid hemorrhage. Why we need to know the severity? Because based on the severity, we can assess the prognosis and the treatment outcome, right? So this is the first scale, which is the modified Hunt and Hess clinical grades. It starts from 0 and goes up to 5. 0 means an unruptured aneurysm. 1 means asymptomatic or minimal headache. 3 means drowsiness, confusion, or mild focal deficit, and 5 means deep coma, deep cerebral rigidity, or moribund appearance. So usually based on this Hunt and Hess scale, we call it as good grade aneurysm or a poor grade aneurysm. So what do you mean by good grade? Good grade means 0 to 3. Up to 3, you can call it as good grade aneurysm, but poor grade aneurysm means either a grade 4 or a grade 5. And on top of that, if you have any comorbidity like hypertension, diabetes, your score will go 1 plus, right? So if you fell in the score of 2 with a hypertension, you will fall in the score of 3. And then comes the WFNS grading based on GCS and the presence or absence of motor deficit. Grade 1 is GCS 15 without motor deficit. Grade 2 is 14 to 13 without motor deficit. Grade 3 is 14 to 13 with a motor deficit. And likewise, grade 5, a patient who is in coma, doesn't matter whether the patient has a motor deficit, yes or no, right? So higher the grading, poor is the chances of treatment outcome. So grade 4 and 5 again in WFNS are poor grade aneurysms. Grade 1 to 3 is still all right, good grade aneurysms. Based on radiology, initially we used to follow Fisher's grades. Now we are following the modified Fisher grade. It again 0, 1, 2, 3, 4. So 3, 4 again falls in the category of poor grade aneurysms. If you can see, there is slight modification in this aneurysmal grading in the sense that a patient who has a IVH either falls into grade 2 or falls into grade 4, correct? So a patient who has an IVH will fall either in grade 2 or grade 4. Only in difference is that is a thin collection of blood in grade 2, whereas in grade 4 it is a thick collection of blood. So higher the Fisher grade, again poor are the chances of survival or increased chances of morbidity. So we have mentioned this. So what is the significance of gradings? Higher the grade, more the chances of important complications like vasospasm. There are higher chances of elevated intracranial pressure. There are chances that cerebral autoregulation may be impaired, disordered cerebrovascular response to hypocapnia, higher chances of cardiac arrhythmias and myocardial dysfunctions, and higher tendency for electrolyte and fluid imbalances, right? That is why we need to understand all the gradings, whether be Hunt and Hess, whether be WFNS or a Fisher grading. So let us come to the management of cerebral aneurysm. Management broadly depends on the location and the size of the aneurysm, whether it is ruptured or it is unruptured, and individual patient's choice. Patient may say directly that in this case, I want a coiling, because if the patient has been given an option, you want coiling or clipping, patient has the full right to decide whether the patient wants coiling or clipping. So the different modalities are microsurgical clipping, endovascular coiling, or endovascular therapies, or flow diversion with stents. Let us come back to the recommendations. For patients with aneurysmal subarachnoid hemorrhage, the ruptured aneurysm should be evaluated by a specialist with endovascular or a surgical expertise to determine the relative risk and benefits of either a surgical or endovascular treatment according to patient and aneurysm characteristics. So as early as the diagnosis is confirmed, it should be evaluated by a radiologist, neuroradiologist, or a neurosurgeon to, and based on the patient or the aneurysm characteristic, they should decide whether the patient needs coiling or patient needs clipping. This is class 1 recommendation. For patients with aneurysmal subarachnoid hemorrhage, either a coiling or clipping, whatever you do, but it should be performed as early as feasible after presentation, preferably within 24 hours of onset to improve outcome. This is a class 1 recommendation. Get a coiling or clipping done as early as possible, preferably within 24 hours to improve the outcome. Then comes the treatment goal. What is the treatment goal? Class 1 recommendation, whether you do a coiling or whether you do a clipping, there should be complete obliteration of the ruptured aneurysm, right? You should completely obliterate the aneurysm. But again, if by some reason you are not able to completely obliterate the aneurysm, then partial obliteration, do the partial obliteration and try to retreat it again in a delayed fashion in those patients in whom functional recovery is likely to be good, right? This is a class 2 recommendation. Now comes to clipping or coiling. What do you want? Clipping, coiling based on the aneurysm? Yes, the recommendations are there. So class 1 recommendation for patients with good grade aneurysmal SAH. Now I mean to say good grade means either a modified Fisher 1 to 3 1 2 or a Hunt and Hess 0 1 2 3 or a WFNS 1 2 3, right? So good grade aneurysm, if both coiling and clipping are possible, then primary coiling is recommended in preference to clipping to improve 1 year outcome. So if you think in improving 1 year outcome and if the both options are available, then coiling is preferred, right? But if you want to look at the overall outcome and both the options are available, then both are all right. You can do either a clipping or you can do a coiling. That is a grade 2 evidence, right? And if the ruptured aneurysm is from the posterior circulation, then coiling is always indicated in preference to clipping to improve outcome. Class 1 recommendation. For anterior circulation aneurysm, coiling is preferred over clipping to improve 1 year outcome. But for overall outcome, both are equal. For posterior circulation, coiling. For patients with aneurysmal subarachnoid deemed salvageable and with depressed level of consciousness due to an intraparenchymal hematoma. So the SAH has now caused ICH, intracerebral hemorrhage. Then better you go for a emergency clot evacuation, class 1 recommendation. For patients or for geriatric patients, the superiority of coiling over clipping has not yet been determined. So again, it will depend upon the patient characteristics. But for younger patients, less than 40 years of age, there is a grade 2 evidence that clipping probably is slightly better than coiling because it improves the durability of the treatment and outcome, right? So then comes the complications of aneurysmal subarachnoid hemorrhage. Two major complications what we fear whenever a patient of aneurysmal subarachnoid hemorrhage comes to us is rebleeding and vasospasm. Rebleeding is most commonly within 72 hours and highest within the first 24 hours, right? And vasospasm, it starts on the 4th day, peaks on the 7th day, goes up to 14 days, right? So that is vasospasm. Two most bad complications of aneurysmal subarachnoid hemorrhage. One is rebleeding, the second is the vasospasm. So are there any measures to prevent rebleeding? So now we are concerned about rebleeding and vasospasm. Are there some measures? Yes. So in any patients with aneurysmal subarachnoid hemorrhage and unsecured aneurysm, mind it, unsecured aneurysm, patient has come with aneurysmal bleed, but no coiling or clipping has been done yet. So aneurysm is unsecured. So what you need to do, frequent blood pressure monitoring and BP control with short acting medications. That is a class 1 recommendation. So frequent blood pressure monitoring. Do not allow the blood pressure to surge or increase drastically or abruptly. Control the blood pressure. In patients with aneurysmal subarachnoid hemorrhage who are receiving anticoagulants and now has come with subarachnoid hemorrhage, emergency anticoagulation reversal is the rule, and this is again class 1 recommendations. In patients with aneurysmal subarachnoid hemorrhage, routine use of antifibrinolytic therapy like tranexamic acid is not recommended. There is no benefit, and it level of evidence 1 class falls under recommendations number 3. So there is no benefit of routine use of tranexamic acid to in patients with aneurysmal subarachnoid hemorrhage. This is the latest guidelines. Can you do something to prevent vasospasm and delayed cerebral ischemia after aneurysmal subarachnoid hemorrhage? Yes, the age-old concept, the class 1 recommendation, as soon as the patient is diagnosed with aneurysmal subarachnoid hemorrhage, start enteral nimodipine 60 mg 4 hourly. This is class 1 recommendation and continue it up to 21 days, right? And second, class 2 recommendations, maintain euvolemia throughout the perioperative period as well as in the intensive care unit. Try to maintain euvolemia. There is no role of hypervolemia. It causes harm rather than any benefit. In patients with aneurysmal subarachnoid hemorrhage and symptomatic vasospasm, mind it, I am saying a symptomatic vasospasm, right? You can elevate the systolic blood pressure to reduce the severity of the delayed cerebral ischemia. But again, the level of evidence is on a lower side. It's just 2B recommendations. In patients with aneurysmal subarachnoid hemorrhage and severe vasospasm, you can go for intraarterial vasodilator therapy. Again, comes with a low-grade evidence. No routine use of statins or magnesium therapy, and no routine hemodynamic augmentation, right? So patients who are not at risk of vasospasm or not at the risk of DCI, please do not prophylactically increase the blood pressure of the patients. Increase the blood pressure only if you have diagnosed it as a case of vasospasm and the patient is at risk of DCI, right? Timing of surgery, as I mentioned earlier, get the surgery done as early as possible. Class 1 recommendation, preferably within 24 hours. So pre-anesthetic consideration, do a thorough assessment of the patient's neurologic condition and grade the patient according to the grading, whether WFNS, HNH or Fisher gradings, right? See the scans, try to find additional parameters, ICP or a TCD finding, the baseline blood flow velocities in the larger cerebral arteries. Communicate with the surgeon regarding the positioning, anticipated difficulties, or any special monitoring if at all is required. And of course, if you have that permissibility of the time, try to optimize the patient's physiological condition as well as any other comorbid condition that what patient has presented to you. But rarely you get that window to optimize the comorbidities of the patient. What you can do is that bring the physiological parameters as close to as normal till the time of the perioperative period. Intraoperative considerations, we know that we have to maintain the cerebral perfusion pressure, which is the difference of the mean arterial pressure and the intracranial pressure. Please try not to increase the blood pressure by any means or try to prevent fluctuations of the blood pressure. This may lead to aneurysmal rupture. One of the very important cause of aneurysmal rupture intraoperatively. It may happen during the early phase, it may happen during the dissection phase, or it may happen during the clipping phase. Till the aneurysm is clipped, please tightly maintain the blood pressure, right? And try to maintain the cerebral perfusion pressure. That's it. Maintain the CPP and maintain the blood pressure. Induction of anesthesia is usually the same technique which everyone is doing, but yes, be sure avoid abrupt increase in the blood pressure secondary to your laryngoscopy or intubation. Make it very smooth. Agents, you can go as per your own choices like propofol or a fentanyl or a remifentanil, whatever. This the common agents we use, muscle relaxants as per your choices. Monitoring, usual monitorings are always there, but yes, invasive IBP monitoring will almost always be there in every case of aneurysm. Central venous pressure monitoring, again, basically to guide your central venous pressures, or you may require some vasopressor therapy at that any point of time. So CVP monitoring, not very high evidence, but yes, better to use it if in confusion, right? Or if the aneurysm is a complex giant aneurysm, time-taking surgery, better to use it. Intraoperative neuromonitoring may be reasonable to guide anesthetic and operative management, but as far as the recommendations are concerned, it's a low level of recommendations, right? So you may go for cerebral oximetry, TCD, or SCCP intraoperatively. Positioning will depend on the location of the aneurysm vis-a-vis the position will be as per the location of the aneurysm. Head pin, we apply the Mayfield head pin. So these are noxious stimuli. Please try to blunt the response of the pin insertion and prevent hemodynamic responses by any agent you want to use, you are convenient with. Maintenance of anesthesia, it's the same thing. Try to maintain a relaxed brain, maintain adequate perfusion to the brain, and try to reduce the transmural pressure, right? Do not abruptly increase the mean arterial pressure, correct? And maintain hemodynamics. And again, in patients with good grade aneurysmal subarachnoid hemorrhage, the routine use of induced mild hypothermia is not beneficial. Rather, it will cause harm. It may lead to coagulopathy. It may lead to delayed awakening. Important, yes, maintain normovolemia either in the OT or in the ICU. There is no role of hypervolemia. It causes harm with a it really causes harm. So maintain normovolemia, right? Try avoid using a glucose containing solutions because both hyperglycemia and hypoglycemia worsens outcome, and it comes with an evidence, moderate evidence that prevent hyperglycemia and hypoglycemia, right? So normal saline would be good enough, but yes, if your surgery is taking place in a manner that you need to transfuse more and more fluids, try to use a balanced salt solution. In that way, you can cut down the chloride concentration of normal saline. Brain relaxation, again, the same techniques. Optimize the neck position. You can, if required, make the head end up by 10 to 15 degree. What we conventionally use is a mannitol or a hypertonic saline. Both are equivalently good. Comes with a moderate evidence that yes, you can use a mannitol or you can use a hypertonic saline depending upon the hemodynamic condition of the patient. Even if then brain is not relaxed, you can simply go for a total intravenous anesthesia. Try avoid using vasodilators like nitrous oxide or a volatile anesthetic agents. And if at all required, particularly during intraoperative aneurysmal rupture, you may have to institute hyperventilation for a short duration of time till the aneurysm is secured, right? So these are the common goals: maintain normotension, maintain normovolemia, maintain normocarbia, normoxia, normothermia, and normoglycemia. These are again very standard practices of neuroanesthesia. It applies same in aneurysmal patients. Emergency and recovery aim is maintaining smooth emergence. It depends on you what kind of agent you want to use to prevent the cough and the buck responses. I commonly use lignocaine in a dose of 1.52 milligram per kg. People use Dexmed also. So it all depends upon your expertise and the patient's condition. But yes, do not allow abrupt increase in the blood pressures, right? Immediate post-operative considerations, again, at times there may be delayed recovery. Then it is uh, very pertinent to determine whether it is due to residual anesthesia or from surgical complications, right? We do understand the differences that anesthesia causes global depression, while new onset focal deficit will be related to a surgical cause, right? Inhaled anesthetics by at large will at least get eliminated by 60 minutes. So even after the patient is not waking up after 60 minutes, think of the surgical cause, right? If the pupils are very small pinpoint pupils, try thinking of narcotic overdose, correct? And try to assess neurological condition of the patient every 15 minutes. This is very important. So then comes the endovascular therapy. We are done with clipping. Now comes the endovascular therapy. The endovascular therapy again can be basically divided into two groups. One is the reconstructive techniques. The other is deconstructive techniques, right? Reconstructive techniques includes the simple coiling, which is the simple coiling. It can be done with a stent. It can be done with the balloon, which is balloon assisted coiling, then stent assisted coiling, or you can straight away go for flow diversion, right? Flow diversion techniques by inserting a or placing a flow diverter, right? And deconstructive technique means you are not handling aneurysm at all, right? You are just you are doing a parent artery occlusion and trapping. But again, we do have lot of concerns when we are doing a case in a cath lab, because it's a remote location to us. We are more familiar to OT atmosphere. The cath lab are a remote location. The chances of complication, the catastrophes, and managing the equipments and the instruments, the space, the manpower, it's very difficult, right? Patient access is difficult. Also the equipments. I'll show you a typical suit, a typical diagram of an INR suit. Again, at times it becomes very difficult to decide whether the patient, whether we should give GA to the patient, or it can be done under local or conscious sedation. But whatever, try to decide it before the procedure, whether the patient requires GA or LS. There is no difference in the outcome with regards to the anesthetic technique, right? The literature doesn't say anything about the outcome with regards to anesthesia technique. You can use anything, but at least be sure what you want to use before the start of the procedure. Any conversion during the middle of the procedure is very hazardous. Suppose you have started the case in a conscious sedation, then intraoperatively patient dips in or something happens, converting to GA, then it becomes really difficult because the space is very less. Patient is heparinized, you do a laryngoscopy, chances of bleeding are there. Things get difficult then. Again, the cath lab is very cold. The chances of hypothermia is there. During the procedure, patient will be receiving a loading dose of heparin followed by a maintenance dose of heparin. So there are chances of anticoagulation, particularly if there are multiple aneurysms, 2 aneurysm, 3 aneurysm. Cath lab radiologist is trying to secure 1 aneurysm with the anticoagulant. The other aneurysm is at risk of getting ruptured. Again, they are using a contrast, which is an iodinated contrast. The contrast related reactions, we have to understand that. And of course, the radiation hazards when a patient is being done under angiograms. So these are the very important considerations. Everything is important. This is a typical INR suit. Just see the scanner above the patient's head. So if any catastrophe occurs in a patient who is being done coiling under LA or conscious sedation, then getting things done, uh, intubating this patient on anticoagulation, it becomes very, very difficult. So again comes the recommendations, endovascular adjuncts. The recommendations says that for patients with aneurysmal subarachnoid hemorrhage with ruptured white neck aneurysms, not amenable to surgical clipping or primary coiling, then stent assisted coiling or flow diverters is reasonable to reduce the risk of rebleed, right? A patient with a wide neck aneurysm, you are not able to do a coiling or a clipping, then stent assisted coiling or flow diverters are all right. This is a grade 2 recommendation. But if it is amenable to coiling or clipping, wide neck aneurysm amenable to coiling or clipping, then do not use stents or do not use flow diverters. It causes more harm rather than the benefit, right? And with a blister or a fusiform aneurysm, you can go for a flow diverters. So how do flow diverters work? Flow diverters doesn't actually do anything to the aneurysm. What they do is that they cause aneurysm to get thrombosed over a period of 6 to 12 months by the process of endothelization, by the process of luminal reconstruction by endothelization, right? So this is the process of this one. The peri-procedural technique remains the same. You have to identify the patient selection, make sure you want to give GA or CS, conscious sedation or LA, decide in the beginning, take a appropriate consent, try to optimize the physiological condition and the comorbidities if it gives you the time. Take previous history of exposure to contrast agents and protamine allergy. Very, very important, because at times you might need to reverse heparin, particularly in cases of intra-procedural bleed. You might require protamine. Then you should know the history, whether there is any protamine history, allergy or protamine history or not, right? So peri-procedural complications can be broadly either a hemorrhage can occur either due to the technique. uh, there may be hemorrhage, there may be rupture of the aneurysm, there may be rent in the large blood vessels, right? Or it may be an occlusive phenomenon. There may be thrombus, the coil may migrate. There are cases where the coil has migrated to other sides, right? So there may be, or there may be a diagnosed case of vasospasm. So hemorrhagic and occlusive complications both can happen. Other than that, anaphylaxis may happen due to contrast agents, or later on due to the puncture site in the femoral artery, there may be hematomas, right? So these are the three important things. Remember about anticoagulation, radiation, contrast agents, all have to do with complications, also hypothermia in the cath labs, right? Radiation hazards, it may be direct from the X-ray tube, leakage radiation or scatter radiation. Just see, interventional cerebral angiogram gives you a radiation of 7 to 10 millisievert, which is almost equal to 300 to 500 x-rays. So do not take it casually. Be appropriately downed whenever you are in a cath lab. Wear proper lead aprons, wear a thyroid shield, wear a lead cap. Do not take it lightly, right? You will get exposed to as much as at least 250 chest x-rays by a diagnostic cerebral angiogram. Very, very dangerous. So these are the recommendations. Wear your lead aprons very nicely. Get your batch. This radiation batch is there. Try to wear that radiation batch whenever it crosses the limit. Try to abstain. Try to refrain from going to cath labs for a certain duration of time. Contrast agents, usually the iodinated, non-iodinated contrast agents are used. So there may be chemotaxic reactions, vasovagal, renal failure, hyperthyroidism. Renal failure usually doesn't happen only in cases of predisposed kidney conditions like CKD, then there are chances. Otherwise, in a well-hydrated patient without a history of kidney disease, nothing usually happens unless you have crossed that safe dose of the drug, right? And there may be hypersensitivity reactions. So catastrophes may occur during surgical clipping, that is intra-aneurysmal rupture may occur. Vice versa, intra-aneurysmal rupture may occur during coiling also. So what you need to do, if you are doing in a case of clipping, maintain hemodynamics, if possible, try to take a neck control, do the surgery as fast as possible, and apply the clips, right? And maintenance of the hemodynamics, at best, to a certain degree, you may go for low to normal mean arterial pressure. But in cases of intracranial catastrophe, you will have to reverse the heparin with protamine, but at the same time maintain the mean arterial pressure in either a normal range or just slightly low to normal mean arterial pressure, right? Otherwise, the parameters has to be the same. But remember, if it is a case of intra-procedural rupture during coiling, that has a very bad outcome as compared to a clipping rupture, right? Rupture during clipping. At the end of the procedure, you will have to reverse the anticoagulation, try to maintain a smooth, rapid recovery. Post-procedure, what is most important is try to every 15 minutes have a neurological assessment of the patient, try to maintain the hemodynamics, fluid status, and the puncture site, right? Because patient was on heparin. If you do not take adequate assessment of the puncture site, there may be swelling and later on a pseudoaneurysm might develop, right? So in summary, cerebral aneurysms present a unique challenge to the anesthesiologist whether the patient is amenable to coiling or clipping. In both the situations, the anesthesiologist have to be on foot. They need to understand the pathophysiology. They need to understand all the gradings of aneurysmal subarachnoid. They need to prognosticate the patient at every step, whether it be in OT, whether it be in ICU. They need to understand what are the important complications, when to prevent rebleeding, what to do during rebleeding, what to prevent vasospasm, how to prevent vasospasm, how to treat vasospasm. So these are the important considerations for dealing with a case of aneurysmal subarachnoid hemorrhage patients. So what is required is that thorough understanding of this disease condition and the perioperative goals, objectives, and the planning and the complications. Thank you all. Thank you everyone for your patient listening.
Thank you, Dr. Ankur, for very lucidly telling about all the considerations of aneurysm and how to be managed. And I think so we still have around 15 minutes. We'll take the questioning in the end. And for the next, I'll be doing some literature search for the recent articles which have come up in concerning to neuroanesthesia and neurocritical care. And I'll be just dealing with around 4 or 5 slides. So the first study that is there, which is a very recent guideline which has come up about the airway management in a patient with a confirmed or a suspected cervical spine injury. And these guidelines have come from Difficult Airway Society in UK, Association of Anesthesiologists in UK, British Society of Orthopedic Anesthesiologists, Intensive Care Society, and Faculty of Pre-Hospital Care, Royal College of Emergency Medicine, and it's been recently published in Anesthesia Journal. And sorry. So there's always been a conflict. What is the optimal way of airway management in these patients who have either a known cervical spine injury or a suspected cervical cord injury, and there is no evidence-based guidelines. So because of this, they have done a literature search for articles which is published between 2012 to 2022. And in 3-round Delphi procedure, they have taken some experts, and these experts have seen around 67 to 70 articles, and they have come up with certain recommendations for these group of patients. And the recommendations which have come up is, these are the broad guidelines, which are the recommendations which have come up. So the first recommendation is attempt should be made to minimize the cervical spine movement during pre-oxygenation and face mask ventilation. It's a very weak recommendation, a grade D recommendation. Whenever a simple maneuver is required to maintenance of airway, jaw thrust is the only recommended airway maneuver that is required. Again, a weak recommendation. The third is if tracheal intubation is required through a sorry. The third is if a tracheal intubation is required through a supraglottic airway device. What has come up is there is no device which is superior to any other device. There was always a conflict with which device is better. So whatever supraglottic device we use, the aim should be reducing the cervical spine movement to facilitate a successful tracheal intubation, and the clinician should use only that device with which he is familiar with and which is available to him. This is a strong recommendation which has come. And the other strong recommendation which has come as a second generation supraglottic airway device should be preferred over the first generation supraglottic device. Again, a very strong recommendation. The next recommendation which has come up is the use of video laryngoscopes for tracheal intubations. And this is again moderate recommendations, but what has come up now, rather than using the Macintosh blade which we were there, we should now use a video laryngoscope, because there it is possible to do an intubation without much of cervical movement. The clinician should be very well versed with the use of a video laryngoscope. That is a next recommendation which is there. And during a use of video laryngoscope for intubation, the use of stilet and bougie should be used in those conditions where the cervical spine is immobilized. So these are the recommendations which has come up. These patients are usually on the rigid cervical collar. So whenever an intubation attempt is being made, removing the anterior part of the cervical columns helps to minimize the movement and should be done. And a multidisciplinary planning, preparation, and optimization of human factors should be considered before attempting an airway management in any of these patients who have either a suspected or a confirmed cervical spine injury. So this is the first paper which has recently been published. The second paper which is there is the use of tenecteplase for stroke patients, because between 4.5 hours to 24 hours, and this should and these are the patients who have been monitored by a perfusion imaging selection. And this is a new article which has come up in February 2024 and published in New England Journal of Medicine. And the experts were from the Timeless Investigator group, which come up with this. Use of thromboelastic agents were usually considered within 4.5 hours after the onset of acute stroke, and whether the use of them beyond 4.5 hours was very limited. So a multicentric double-blind randomized placebo-controlled trial was done in patients of ischemic stroke who compared the use of tenecteplase with placebo, which is administered between 4.5 to 24 hours post-stroke. And these patients were those patients who had evidence of occlusion of either a middle cerebral artery or an internal carotid artery, which was salvageable patients, and it was determined by a perfusion imaging. The primary outcome which was seen was a modified ranking score between 0 to 6 at 90 days, and safety outcome include death and symptomatic intracranial hemorrhage. So in this trial, they have taken 458 patients, and 77% of them underwent thrombectomy, out of which 228 patients received tenecteplase and 230 received a placebo. And the median time of administration of tenecteplase was around 13 hours post-injury, and in placebo group was 13 hours post-injury. And the median score of modified ranking scale was 3 in both the groups. And they found the mortality at 90 days was around 19.7% in patients who received tenecteplase versus 18.2% patients who received placebo. And the incidence of symptomatic intracranial hemorrhage was approximately 3.2% in tenecteplase patients versus 2.3% in patients who received placebo. So they concluded with this study was, if it is initiated between 4.5 to 24 hours after stroke in patients with a middle cerebral artery or internal carotid artery occlusion, the result did not differ, resulted in a better clinical outcome with the use of tenecteplase rather than those patients who were given placebo. The incidence of symptomatic intracranial hemorrhage was almost similar in both these patients. So the use of tenecteplase beyond 4.5 hours did not have any advantages over the placebo group. The third study which recently came up, which was published in British Journal of Anesthesia in May 23, was the use of targeted temperature management in patients with intracerebral hemorrhage, subarachnoid hemorrhage, or acute ischemic stroke. And this was an updated consensus guidelines recommendation by a neuroprotective therapy consensus review, which was a NTCR group, which came up with these recommendations. And the aim of this was to publish consensus recommendation on targeted temperature management after intracerebral hemorrhage or aneurysmal subarachnoid hemorrhage or acute ischemic stroke. And there they used a 19 international neurointensivist care experts, which formed a consensus over these guidelines, and a threshold was more than 80% of the consensus were required to form a guideline. The recommendations was formulated on the basis of existing evidence, literature review, and consensus. The core temperature should ideally be monitored continuously or maintained between 36 and 37.5 degrees using an automated feedback control device where possible. And targeted temperature management should be commenced within 1 hour of first fever identification in these group of patients with an appropriate diagnosis and treatment of infections. And any amount of temperature lowering which was done, rewarming should be in a very controlled manner. So based on these, the recommendations which was there was how to use a targeted temperature control. It should be, they came up with 100% consensus that it should be used either continuously or at least hourly. The core body temperature was the most useful surrogate measure for brain temperature in this, which the level of consensus was approximately 90%. An automated device for targeted temperature management is indicated for high quality temperature control for treatment of neurogenic fever in adult patients. 100% consensus was there. The targeted temperature management should be used reactively and using an automated device to maintain normothermia. The target temperature which was to be maintained was between 36 and 37.5 degrees. Again, 100% consensus was there. The maximum temperature variations which was recommended was plus or minus 0.5 degrees centigrade per hour or less than 1 degree per 24 hours. The temperature control should be used as long as the brain was at risk of secondary insult. Again, a 90% consensus was there. An automated temperature targeted device that enable precise temperature control is desirable. Again, a 95% consensus was there. The maximum temperature I have already said. The neurogenic fever in patients can adversely affect the patient's outcome, and it was important to treat or prevent both these neurogenic fevers in this group of patients. So this was again a consensus of between 95%. And once fever is detected, controlled temperature management should be initiated again within 1 hour, again 100% consensus. And when used reactively, once fever is detected, TTM should be initiated with automatic devices in these patients set up at 37.5 degrees. Shivering was an important problem which was there, and it should be controlled in all this group of patients. What should be the first line of treatment for control of shivering? There was no consensus among the experts, but controlled rewarming should take place at the speed of less than 1 degree centigrade per day. Normothermia should be applied in a slow and controlled fashion. And outcome assessment, what was the valid metric for measuring the quality of TTM delivery? There was again no consensus. So this was another targeted temperature management therapy, which there was a consensus which come up. Yes, the temperature should be decreased or increased so as to maintain as near as normal between 36 to 37.5 degrees, and use of specific devices to control the temperature is indicated in this group of patients. Another study which was published in Anesthesia and Analgesia in May 24 was anemia and optimal transfusion thresholds in brain injured patient. I'll just go through the summary. The summary said there was no difference between the temperature between maintaining of hemoglobin of 7 degrees or 10 or 11 gram percentage in patients of traumatic brain injury, aneurysm, subarachnoid hemorrhage, intracerebral hemorrhage, or acute ischemic stroke. And in this era, whether the patient should be transfused with the PRBC or not should depend on the clinical parameters, advanced monitoring, and the brain tissue oxygen sampling in this group of patients. And a holistic approach should be used rather than going in for one single measurement of hemoglobin. One other study which came up was a trial of thrombectomy for a stroke in a large infect of unrestricted size, which again was published in May 2024 in New England Journal of Medicine. And here the patients who had a proximal cerebral vessel occlusion were assigned in 1:1 group. And these patients had a large infarct in them. And it was said whether these patients should be undergo endovascular thrombolectomy or receive a medical care, which was a non-thrombectomy group. In this control group, they found a patient with acute stroke and large infarct of unrestricted size. Thrombolectomy plus medical care resulted in a better functional outcome and lower mortality than those patients who were managed with medical care alone. So thrombolectomy should be performed in this group of patients, and it has a better outcome. And one last study, which I'll say recently published in Journal of Stroke and Cerebrovascular Disease, was the use of lactate to albumin ratio as a promising predictor for 28 days mortality in critically ill patients with acute ischemic stroke. And the conclusion with this study was the use of lactate to albumin ratio emerged as a promising predictor for all case mortality in acute ischemic stroke patients who are admitted at an early stage, and when they are seen within 28 days of admission, it gave a good prognostic value in these patients and should be monitored in neurocritical care. So these are 5 studies which have come recently, and so this is all which is there from my side. I'll see if I'll now ask the audience if the audience have any questions. I don't think I cannot see any question out here. From my side, Dr. Ankur, I have just a question for you.
Yes,
Doctor,
sir.
Dr. Ankur, nowadays sometimes we do get patients with large cerebral aneurysms. So do you think is there any role of flow arrest in these group of patients while clipping the aneurysms? Some
Sir,
drugs, some drugs
yeah,
have
yeah.
some drugs have come where you try to stop the blood flow to the aneurysm or to circulation you want to stop.
So
And
first of all, if you're talking of giant aneurysms, let me first tell what are the different ways by which giant aneurysms can be treated. First is the conventional technique by surgical clipping, or second technique is by taking a neck control. So you do a temporary venous occlusion by a neck control, you reduce the vascularity, and then you can go for a clipping of the giant aneurysm. Or third technique is the bypass technique. So extracranial, intracranial bypass technique can be done to secure the aneurysm, to bypass the aneurysm. When the flow to the aneurysm will be reduced over a period of time, it will get thrombosed. So these are the three techniques. Regarding the flow arrest, if you are doing by a conventional technique, and if you want to reduce the vascularity of the aneurysm during the procedure, usually the drug which is used is adenosine. But again, the recent recommendations from the ASA says that even though adenosine can be used, but it comes with a low level of evidence, grade 2B, to be used for flow arrest. Otherwise, usually a proximal control, and then you can clip the aneurysm.
okay. Okay, that's all from my side, and I don't see any questions from the audience. Questions are not there.
Sir, we have not received any question yet.
Mhm.
Vineet? Vineet,
Yes, ma'am. Yes,
are
ma'am.
you want to then conclude if there are no questions?
Yes, ma'am. Yes, ma'am. There are no questions. We can conclude the session.
Uh-huh. Um, right. So at the end of the webinar, which has been very extensively covered by Dr. Sanjay, Dr. Priyanka, and Dr. Ankur, such valid topics that are so important for all of us to know: the new techniques, the clipping, coiling, the intracranial pressure monitoring, and also the recent trials that Dr. Sanjay all told us about. The 5 journals were very, very educative, and it's so important that we should be up to date in our knowledge for all these. So thank you very much, all of you, moderators, speakers. Thanks a lot, Dr. Sanjay, Priyanka,
Thank you.
and Ankur. We really, everybody enjoyed, and thanks a lot. This was actually a super specialist job which you have done. Thank you. Thank you, Vineet. Thank you, Shreyashi. And hope to see you all next week or sometime soon. Thank you very much.
Thank
Good
you, ma'am.
night.
Thank you,
Thank
ma'am.
you. Thank
Thank
you.
you. Good evening, ma'am.
Thank
Thank you,
you.
ma'am. Thank you,
Good.
sir.
Thanks
Thank
a
you.
lot. Bye. Bye.
Thank you,
you,
ma'am.
ma'am.
Good night.
Bye, dear.
Good night, everyone.
Yes.
Bye.
Good
Bye.
evening, sir.
Shreyashi.
Good
Bye.
evening. Good evening, Sanjay, sir.
Bye, dear.